Welcome to episode 2 of The Wellness Effect. We are almost, it seems like, halfway through 2025, but we're only in February, the month of love. And my co-host Dwayne got here late because he's been buying several Valentine's gifts. Ladies, if you're listening, that was a direct quote. But we're here in the month of love and heart health. And joining us as a special guest is Dr. Don Scantlebury, who is a colleague, an interventional cardiologist, and a champion for women's health in heart disease, really. It's so great to have you on the set, Dawn.
It's great to be here, Kenneth. Thank you for inviting me.
Sure, anytime. And Dwayne is of course, thanks for joining again. After the first episode, we had a lot of fun.
Yeah,
Today is going to be even more informative because we need to drill down into a very serious issue, Dwayne.
Yeah. So I just came across a report that cited cardiovascular disease is the leading cause of death among women globally, accounting for approximately 35% of all female deaths.
Right.
Mm-hmm. That's crazy, guys.
It is crazy.
So when you add up everything, cancers, infections, heart disease, etc., all the many things that can cause someone to depart this mortal coil, and then you divide it up. Heart disease, cardiovascular disease is still 1/3. It's a full 1/3 of all cause deaths.
That is incredible. So even though I got my pin wrong and actually wore the pin for breast cancer, here's something you didn't know, that cardiovascular disease in women accounts for 13 times that of breast cancer. So we have a big observation of breast cancer awareness month in, is it October?
Yes, it's October.
In October. But yeah, we're here in February and 13 times the amount of death. And we're not making this big a deal about it. So it's something we need to focus on, heart disease in women. And also maybe what steps can we do as a healthcare profession to address it as well?
Yeah. I think one of my concerns is that given that statistic, it's so glaring, it's so alarming, and that's women globally.
Yes.
I would like to know, what is the picture like for Afro-Caribbean women? Mm-hmm. And we might not get the statistics now, but what do you think are the drivers for cardiovascular disease?
To answer the first question, cardiovascular disease is still the number one cause of death in women in Caribbean and Barbados. There are some interesting statistics for cardiovascular disease in general. In the Americas, the Caribbean region is leading, and Barbados is leading as far as the region of the Americas as far as cardiovascular disease deaths. And people always think of men when they think of heart attacks, etc. Yeah. But cardiovascular disease is still the number one cause of death in women as well. There are some interesting statistics in African Americans, I would say, because America is where you get a lot of the data from, and African Americans have unfortunately they have even a higher risk of cardiovascular disease than the average
compared to the rest of American women.
Yeah, compared to the rest of American women.
Yeah,
and African Americans in general. So you come to Barbados, we're a predominantly Black country, Afro-Caribbean, using that term. And a lot of the same drivers for cardiovascular disease that are seen in those women, in Afro or African-American women, are the same here in Barbados. Yeah. So overweight and obesity, big deal. It's I don't know how much that passage across the Atlantic has to do with it. Or shared background as far as slavery and segregation, etc., and more of a crop-based, carbohydrate-heavy diet leading to an increase in the risk of diabetes, and then the higher risk for hypertension. So hypertension is a huge cause of cardiovascular disease. But then there are some peculiarities. So Black women have a higher risk for preeclampsia, and hypertension in pregnancy, so the hypertensive pregnancy disorders. And hypertensive pregnancy disorders lead to 4 times increased risk of cardiovascular disease, a doubling in heart attacks, a quadrupling in things like atrial fibrillation. So overall cardiovascular disease in general. So preeclampsia is a condition where women develop hypertension during pregnancy or immediately after. It could either be a problem that arises on top of known hypertension or arises de novo in pregnancy. And it's high blood pressure associated with end organ damage, so they can get kidney problems, leg swelling is a big problem. It used to be known as toxemia of pregnancy, is what it used to be called. And black women have a higher risk.
A higher risk for it. But it's interesting because in my practice, I see a lot of women who've had preeclampsia or even hypertension, pregnancy-induced hypertension. And I kind of think to myself, these have been referred to me because I would have seen them during pregnancy, so I'm not seeing them in the postpartum or post-pregnancy state. How many women out there had elevated blood pressures and were lost to follow-up? And that's an important gap, because when you think about it, women have a unique opportunity to have what I call a cardiovascular stressor, which is pregnancy, where the entire cardiovascular system is basically like on a treadmill, right? Yeah. And the fact that they are presented to a health system, being seen by obstetricians, but not being handed over to continue risk assessment to primary care docs and internists. I think this is an opportunity of intervention that we are missing with women. And quite often when I see women later in life with hypertensive emergencies like stroke or even heart failure, you go back and they had hypertension in pregnancy.
They had hypertension in pregnancy. So women who've had hypertension in pregnancy develop heart failure at an earlier stage. They develop, I mentioned stroke. Atrial fibrillation is a focus of my research. They develop atrial fibrillation a lot earlier. Atrial fibrillation is an abnormal heart rhythm that can lead to an increased risk for stroke. They develop heart attacks at
And that's when your pulse feels like funny, because a lot of my patients are now wearing these Apple smart watches, which actually picks up atrial fibrillation, and it kind of sends them an alarm saying you are in atrial fibrillation. And this is pretty important because sometimes when I'm seeing them in the office, they're not in atrial fibrillation, so they flip in and out of atrial fibrillation, which diagnostically is a challenge. So it's not something we should take lightly either, right?
Exactly. Yes. So aside from the hypertension in pregnancy, there are other female-specific risk factors for cardiovascular disease. So, women have a higher risk for autoimmune conditions such as lupus and rheumatoid arthritis and other conditions like that. And those are considered risk enhancers where it comes to cardiovascular disease. And then, it's interesting that you should mention breast cancer. So breast cancer and cancer in general is being treated a lot more successfully than it used to be in the past. And the end result of that is that these people survive. And then they go on to develop cardiovascular disease. As a result of their cancer therapeutics. So specifically for breast cancer, there are 2 drugs that we use for breast cancer treatment that have direct effects on your heart. So, and it isn't just the breast cancer treatment, there are other treatments, but the whole field of cardio-oncology is a subspecialty of cardiology that has grown up
considerably
out of the need to treat people's hearts who went through cancer
chemotherapy,
especially breast cancer. So these NCDs are all intertwined. You can't look at them in isolation. So, even though we're talking about the fact that people focus so much more on breast cancer, when
they're all interconnected.
When they survive that breast cancer, then they can go on to have heart disease as a result of the treatment.
I have a question. I have a question. I attended a session last week. I organized on perimenopause, and we invited female staff to this session. I was part of that group. I was surprised to see the kind of risks that are presented during menopause for women. What role does menopause play in terms of increasing risk when it comes to cardiovascular events?
So we have to start from
premenopause. There you go.
So estrogen is protective. So it's considered to be protective.
The female sex hormone, estrogen.
Estrogen. So That's a hormone that is important in, being a woman. It's what leads the female form.
Yeah.
It's what's produced from the ovaries. It's estrogen and progesterone are the primary female hormones, and they're what are responsible for fertility, etc. So it is God's way of protecting us so that we can make sure the human race continues.
Right.
So once fertility wanes and the ovaries are no longer as productive, etc., and we start to go through menopause and we lose that estrogen, the risk for heart disease catches up.
Yeah. And especially in the region of the Americas, which includes the Caribbean region, right? So I mean that is so important. And I'm glad you mentioned staff, but we both, of course, we teach Gen Zers, who I know are watching this on a TikTok video somewhere, right? And Gen Zers, a group of Gen Zers at a university that will remain nameless, said to me last week, why do you keep referring to these symptoms in women as atypical? If half the population are presenting this way, then they're really not atypical. They're just symptoms in women. Do you want to speak to that?
So I'll give you a history of where the whole heart disease in women research movement came from. So back in the I guess 50s, 60s, when we started doing more heart disease research,
right?
The research was kind of confined to men because women bear children, and people were fearful of doing research on women in case they were pregnant, because if you give them something wrong, you affect not only the woman but the fetus as well. So in general, a lot of heart disease research was done in men alone. Not only that, when you look at the primary description of a lot of cardiovascular diseases, they were described in men. So a heart attack was originally described.
Even in all the textbooks and everything, all male images. Man. Usually white man as well, huh? There you go.
Yeah, after a heavy meal, walking out
clenching
his chest. There are actually, pictures and books.
Classic photos.
For surrounding men. So the problem there is that all of this research is done in men. The drugs are researched in men and studied in men, and then administered to women, because clearly women are just slightly smaller
presented.
And over time, cardiovascular disease mortality decreased.
Right.
But then in the early 80s, when they started separating out the figures between men and women, they realized that even though heart disease mortality, so death, was decreasing in men, it seemed like it was still
increasing in women. But that's important, because only if you disaggregated that data would you have identified that. I'm going to come back to speak more about data and the importance of data, especially looking at gender-based data, right after break.
Caribbean people, let's get serious about trans fats. These are industrially produced fats which clog arteries and are found in many processed, fried, and baked foods. They need to go. Policymakers, remember our commitment to eliminate trans fats from our food supply by December 2025? We must follow through. Eliminating trans fats can help prevent so much suffering and death from heart disease, curb soaring healthcare costs, protect our region from being a dumping ground for unhealthy products. Because let's be real, if we don't regulate, we will continue consuming products with trans fats that many other countries have banned because of the danger. Trans fats kill. Let's develop and enforce policies to ensure we're not making or importing this harmful substance. Eliminating them is a win for all of us.
We are back, and I know you can't hear the background calypso, but we actually did get some steps in during the break, got our heart rates up, and we're all settled and hydrated and ready to discuss this fascinating anomaly of women presenting with heart disease to the health system. Now, Dawn, I'm on call today with the university team. Inevitably, I would say between half to 2/3 of our admission are going to be women. Of course, wrongly classified as presenting with atypical symptoms, but really just symptoms in women. And what's alarming is looking at data, women presenting with identical symptoms being treated differently in the health setting. So going to the triage nurse and being told, okay, yeah, you might have some gas or some reflux. Whereas men, we tend to be a lot more dramatic and sick and dying. We present the emergency room, we get pushed straight into the stat room, all sorts of things get put on us, and it's a completely different system. And I have a personal experience where in the emergency room doing a night call round and seeing a woman there with just saying, I have some bad feels in what used to be the old 18, which is an area in A&E where you're just on observation. Past the man in stat room, and he clearly had reflux, but was in stat room. This lady was about to go home in a few hours when she collapsed in 18 because she had a heart attack. So these atypical presentations, but there are some biases occurring that we need to address.
Yeah. So, following on from my discussion about women's heart disease mortality increasing, we started looking at how women presented. So, and I suspect that women actually present fairly similar to men. It's just men and women kind of speak different languages sometimes.
We're a bit more dramatic with pain.
Men are babies.
Then was just outside crying.
So the woman is there saying, "Oh, she just has some vague discomfort," and man is probably feeling exactly the same. It's the worst pain in my life. Just kidding. But the problem lies in the fact that all of this research that was done in men has kind of conditioned us to think of heart disease as a man's disease. So you already have biases, and biases are important in medicine to the extent that when you approach a patient, if it's a young patient presenting with chest discomfort, you have your differential diagnoses and percentages, etc. So you still need to have those, not biases, maybe the wrong word, probabilities are what
which we do in medicine all the time.
We have to do that. But the problem is, unfortunately, the word still hasn't gotten out there that those probabilities in women need to be considered depending on risk factor profile and age, etc. So in general, we think of women as being less likely to have a heart attack, whereas that woman 10 years on, older than a man will have the same risk of a heart attack. Remember, there's that catch-up effect. So not necessarily catch-up, but a 10-year delay effect. So if a man is going to present with a heart attack at age 50, a woman will present at age 60.
And the curves tend to come together.
So, the books were written back in 50s, 60s, 70s
by a lot of
research was done in men.
By men. Right.
Research in the literature was on pregnancy. So, that's where a lot of research in women was done, breast cancer and pregnancy, which is why it's difficult to kind of come out from under those biases nowadays and catch up to the fact that women are still affected by heart disease as much as men are. So,
it's phenomenal.
And the only way we can overcome those biases is to talk about it, is to actually publicize it. That is why
and measure it as well.
Exactly. So that's why the American Heart Association came up with this Go Red for Women movement to raise awareness of cardiovascular disease and the risk for cardiovascular disease in women. So
this isn't just coincidence. This is all Sagittar's theme. Going red for women. There you go.
And
now you know where we all dressed in red. Even Dwayne is in red.
Dress.
No other reasons at all.
And of course, they chose February.
And we chose February,
which is my birth month. So we have to celebrate.
We'll sing happy birthday off air.
Birthday. So the whole red dress thing was
public awareness.
It was. Just the red pin could be used for multiple different things. I think AIDS research was
as well.
A red pin. So that's where the red dress came.
But what really struck me is that although it's the number one cause of death in women, almost 50% of women don't actually know it's the number one cause of death.
That's
I mean,
Yep.
where do we start if the population that's at risk doesn't even recognize it
Yep.
as a major risk for mortality?
So going back to the AHA research, when they first started doing these surveys looking at risk, I think it was probably 60-70% of women didn't know that.
They know, yeah. So we have come a long way.
We've come a little way.
Yeah.
It got better and then it got worse again.
Yeah.
And some of that is political and all the research grants, etc., and where research goes. But it's an uphill battle fighting against these biases, even when you survey healthcare providers, so primary care doctors, internists, whatever. There's still a significant proportion of doctors who are not aware of women's risk or do not see it as a priority to discuss with their female patients their overall risk.
Right.
They remember to talk about, breast cancer screening, about breast self-examination, about the mammograms, about pap smears. They remember to talk about what's
Everything related to women's health.
Everything related to women's health, which
which should include cardiovascular disease.
It should include cardiovascular disease. In some fields, in some spheres, it's described as bikini medicine.
Wow.
So when you remember, when you think of women's health, people think of breast health
and pelvic.
Because pelvic is where babies and gynecological issues. That's what they think of when they think of women's disease.
That is very true. I mean, I share a practice with an obstetrician gynecologist, and sometimes when we're in clinic at the same time, I make an observation of who's in the waiting area, and sometimes if I don't recognize my patient, I would say, okay, wait, this patient is not my patient because they're young and fit looking. And then my secretary says, oh, so your next patient is here, and points the young fit looking person who has uncontrolled hypertension. And there I am thinking, this is some person coming in for some gynecological or obstetric issue. And of course, my colleague refers several cases then with postpartum or after pregnancy elevations in blood pressure, and patients who have breast cancer, cervical cancer, other gynecological problems, who are at the gynecologist rightfully to have that check done, but are not thinking about cardiovascular health.
That is
and
big
just
problem.
picked up that their blood pressure is skyrocketed, and they haven't had a diabetes test in like 5 years. Those kind of things.
A few years ago, I actually did a major study on public awareness on heart attacks. It was over 1,000 Barbadians, and what we found, less than half of Barbadians know exactly the correct symptoms associated with a heart attack. Even fewer of them knew about what to do. If during a cardiovascular event like a heart attack, and even after.
So don't just stay at home and drink lemongrass.
It's alarming.
And ginger tea.
So this kind of research is important, I guess, to inform educational interventions. And I would like
public health.
I'd like to have a discussion on the role of education, not just publicly, but in schools and in workplaces. It's really important.
Yeah, it is important. I mean, you mentioned the classic symptoms. So I think the American Stroke Association actually has done a really good job at getting people to think about the symptoms of stroke. And gone are the days when I turn up in the emergency room and people are saying someone just had a Passover and they rub nutmeg, because that's used in Barbados apparently with Granny, and they still didn't. So that's the only reason they brought it to the emergency room. But what is missing, I think, are, again, we need to drill down the features or the symptoms of heart attack. And also get women to know that the symptoms may not be the traditional symptoms that they might hear of described in men. Women, especially older women and older women with diabetes, may have completely different symptoms. But that's one part, and I'm glad you focus on public health education. But what I also think is needed is medical fraternity re-education. So that we are aware, and we just don't, women presenting with those symptoms and saying the right things, but aren't being put in the correct algorithm. A big role. I mean, I actually did another study on patient advocacy, and one of the things that we found, we actually interview healthcare practitioners about their relationships with patients, and the fact that some patients leave everything up to the healthcare practitioner. And I think one of the new movements is to allow the patient, or in this case allow the client, to kind of regain agency Yes.
in
Right.
their
Supported.
healthcare.
Yeah.
And I can see where women can actually sit in that whole discussion.
Oh,
The fact
definitely.
that there could be not just a passive recipient, but
Of care, but active
participant in that same care and planning that care through.
I mean, there's so much to talk about. We're going to come right back. And when we do, we're going to talk about what things can you do to reduce your risk of cardiovascular disease,
Yes.
whether you're a woman or not. But especially if you're a woman, you don't want to miss this, as well as the important work being done by the Heart and Stroke Foundation of Barbados, which is somewhere over there. And Dawn Scantlebury is the president of the HSFB. Coincidentally, she just happened to walk by. I will be right back.
Okay.
Check for pulse.
We are right back after a few steps, and it's now about coming up to 6 p.m. here in Barbados. I hope you've gotten a few steps in. Well, more than a few, maybe at least 4,000 or 5,000 steps. Remember, new data from the American Heart Association showing it's not just making that 10,000 mark, but getting as many steps in as possible. And we're here to talk about heart disease in women, and we hopefully haven't scared you. But even if we have gotten you curious now about solutions, so how do women present? I mean, in terms of what are some of the features? I'm not going to say typical or atypical. What are some of the features in women?
So, just like a man, women present with chest pain, shortness of breath.
Shortness of breath.
That chest pain can be described as pressing, squeezing, or weight, burning. I want to emphasize burning. Doesn't necessarily mean heartburn or reflux. One of the classic symptoms of cardiac pain is burning.
I think that's so important. We hear that quite often.
Yeah, I hear that. Medical students, whoever say, well, you know, it was kind of burning, so
it might be acid reflux. People,
But burning chest pain is actually a fairly classic presentation of angina. And if it's acute, if it's sudden onset, it's either, we call that an acute coronary syndrome. The coronaries are those arteries that supply the muscle of the heart. So acute coronary syndromes are either unstable angina or a heart attack.
And that's a mental emergency, right?
Exactly. That's a heart attack in evolution. If you're having sudden onset chest pain, you're just sitting there, you need to get to medical attention.
And some people at home have GTN spray, which I know they're trying and puffing away. But we should also advise patients that, if you might have stable angina, which is when you get it when you're just moving around doing something. But even if you try your spray and the pain does persist, don't keep spraying. Move towards the emergency room.
Exactly. So chest pain is just about the most common symptom in men and women. But then women often have a lot of shortness of breath on exertion that is related to coronary disease, sudden onset shortness of breath. That chest pain that is classically described as radiating to the arms, radiating to the jaw. Sometimes people can present with that arm pain without the chest pain. Jaw pain without the chest pain. You were talking about, arthritis
in one hand.
No, it's not arthritis. It was actually the radiation, but somehow your body decided not to alert you to the chest pain. Nausea, vomiting, sweating, sudden onset bad feels, the usual Bayesian term, bad feels. Epigastric pain, so pain in the pit of the stomach without the chest pain. There are a lot of these symptoms that can occur in without the chest pain.
Without the chest pain.
That can be related to, that can be seen more in women. And then like headedness and dizziness and fainting.
And palpitations as well.
And palpitations can also be signs of an acute coronary syndrome. So I get people coming to me saying, well, I've been getting this pain, and they say that this could be a symptom of a heart attack, but they've been having this pain on and off for the past 20 years. It's not a heart attack, please. It's not a heart attack.
That's not a heart attack, yeah.
But, if it's sudden onset, or if it is worsened with exertion, or if it's something that you used to get with exertion, exertion meaning walking up a flight of stairs, walking across the room, going and exercising.
But it now is occurring at rest.
That is something you need to pay attention to immediately.
Yeah.
And all of these symptoms I've just described can occur in men, they can occur in women. It's just sometimes women may get more shortness of breath, a little bit more bad feels, and men may describe more pain.
Because men are more dramatic anyway.
Oh boy.
Yeah.
So,
So what are some of the risk factors? And I mean, what can we can do? Look for and reduce the risk. We were speaking about obesity or overweight status, and that being a risk factor. High blood pressure,
high cholesterol,
diabetes, which is something that's being ignored. I know the AHA has done a lot of work in recent times, really driving home cholesterol levels and at least getting a cholesterol panel done. What always annoys me, I'm saying this to colleagues out there, is when I get referrals with patients for uncontrolled blood pressure, and there's a nice blood pressure chart. Maybe they have an HbA1c done for their blood glucose, and there's no assessment of cholesterol status. And so that's important. We need to get that home. And also using the opportunities to tell women, if you are smoking, it's time to stop smoking. If you are drinking alcohol, and we know that. Well, we now know there's no safe limit for cancer risk.
And I think it's worse in women.
And worse in women. And we have data showing that in the Americas, there, at least in one Caribbean country that will remain nameless, it's not Barbados though, where women, the alcohol use is actually higher than men. In women.
Really?
And,
So not only accounting for the fact that women are smaller and abnormal or unhealthy alcohol use is a lesser amount, it's still even more more. And one of my colleagues who you know very well in internal medicine, who is from that Caribbean country, said to me, yep, it's absolutely true. It's culturally normal for young women to go out in the club and drink large quantities of alcohol. So this is something we really need to address as a public health issue. Alcohol leads to increase in weight, hypertension, increases the risk of hypertension.
Comorbidities.
It causes you to sleep deeply and then wake up and have REM rebounds. That's a term in sleep medicine. So it impairs sleep quality, which is another risk factor for cardiovascular disease.
That's a whole different show. We really do need to speak about the quality of sleep, and sleep as an important determinant of cardiovascular risk and health. So that's something that we need to jump on. Any closing shots from either of you on how we're going to address heart disease in women from a physician standpoint, even from the public standpoint? Do we need to be looking more at what the workplace can be doing to decrease risk?
Yeah, I think there's a big space for education for employers. I sit actually on a National Workplace Wellness Committee that's chaired by the Minister of Labour, and one of the initiatives that we're moving very aggressively on is employer education when it comes to wellness. And I think having this whole conversation about women and health, I think it's particularly important that employers understand women's health.
Because half the workforce, at least.
It's so important.
And understand that women's health doesn't just mean bikini medicine.
Exactly.
So even deconstructing those stereotypes and biases, I think, is important, especially for education. But I think my closing remark, though, is that even though as we talk about women's health, I think we have to bring men in the discussion. Because men are partners, men are fathers, men are sons. I mean, I just came from dropping off my grandmother to her cardiologist. And I was there with her. And, I had to make sure that she feels
support system.
So men, because they're part of that support system, they need to be educated about women's health.
Yeah.
Yeah.
I think so.
That's very important. Right?
Well, the other thing, the flip side to that discussion is remember that women tend to be the caregivers in a household.
True.
So when you focus on women's heart health and you focus on educating women how to take care of their heart,
Everyone benefits.
everyone benefits.
The entire family
I
benefits.
actually came across a study like that. It
Yeah.
said that when women are healthier,
The entire family is healthier.
yeah, it's interesting.
Yeah.
This has been a really interesting discussion.
I love it.
And
I love it.
I'm really glad we zoned in this year for heart health in women, especially in the area of in a small and developing country such as Barbados, where the NCD burden is so high, but also where there might be disparities in the way we treat these patients, even when they do present with identical symptoms. This has been the Wellness Effect podcast number 2. We made it through the second one, Dwayne.
Yeah.
But guess what? The third one is going to be even more exciting because we have some strategic tips on health. And I'm not promising any exercising, but yeah, we'll see how things go.
Life's Essential 8.
Life's Essential 8. Tune in next time for the Wellness Effect, episode 3. You've just been listening to episode 2, Heart Disease in Women, with our guest, Dr. Dawn Scantlebury, interventional cardiologist, senior associate lecturer at the University of the West Indies, and president of the Heart and Stroke Foundation of Barbados.
Thank you.
Thank you.
Thank you for having me.
Great.
Yeah, great.